To thank both of you for inviting me today. And yes, it's something that I don't like to see. But again, all of us have these complications, so we'll just be full disclosure. So I'm at the University at Buffalo. My practice is MIS, upper foregut, as well as doing some advanced endoscopy. These are my disclosures. So I know we already covered some of it in terms of the leaks, but leaks are a dreaded complication for any surgeon out there, regardless if it's upper or lower GI. But in terms of the upper GI tract, if it's a benign disease such as gastric bypass or sleeve gastrectomy, the rates are generally lower. However, when you start thinking about oncologic resections, the leak rates are a little bit higher. As you can see with esophagectomies or gastrectomies, it almost goes between up to 10%. Obviously, none of us like leaks personally as a surgeon, but obviously for the patient that has a high morbidity and mortality, not only in terms of the short-term organ, it can lead to like long-term organ dysfunction, and then we're also talking about stricture formation as well as fistula formation, which is going to be talked about later as well. As mentioned, there's a lot of reasons why we try to prevent leaks altogether. It's been shown that it has high mortality rates, readmission rates. It leads to increased hospital costs and decreased patient quality of life. And for oncologic procedures, it can also lead to decreased survival. In terms of, it's also a source of dissatisfaction for both the patient, but also for us. It's a source of medical legal issues as well for us. So it's just something that we all try to avoid. So in terms of management principles, I think, again, there's no real standardized approach. I think it's really just trying to stick to the basic principles of really trying to recognize leaks as early as you can. Because the earlier you can detect the leak, the way we can actually salvage it a lot better. You also want to confirm that diagnosis, and we're going to go through sort of how we do that in the upper GI tract, and then go into more sepsis control. In terms of the later terms of management, I'm going to defer that a little bit to the talks that follow me. So in terms of recognition, it can really range in terms of the presentation. These patients can present with no symptoms at all to ones that are in septic shock on pressors in the ICU. But any patient that's sort of falling off the pathway, not really going towards the traditional route, it is essentially a leak unless proven otherwise. And again, if they have any altered hemodynamics, they have worsening pain, peritonitis, fever, it's really something that you have a high suspicion for. In terms of esophagectomies or in the chest, you do have to worry about any time there's a pleural effusion or a pneumonia, you always have to consider a leak as well. So it's just, those are things that you just have to sort of think about when you start to see things not going exactly as planned. So in terms of how we diagnose it in the upper GI tract, we do have numerous different ways of doing that. In terms of the upper GI, it is a more dynamic study. It is specific, so it actually rules it in, but sometimes you can miss some leaks that are not necessarily detected on an upper GI study. In terms of barium versus water-soluble contrast, if you do have a high suspicion of perforation, you generally want to start with the water-soluble contrast, and the barium is then a second step if it's not detected, just because the barium is a little bit easier to detect the leak, but the barium has the downside of causing a severe inflammatory reaction that is sometimes hard to clear. So that's just something to consider. Sometimes the upper GI is hard to obtain. A lot of these leaks, as all of us have imagined, sometimes happen in the middle of the night, so you can't always get a radiologist to help you with your upper GI. So sometimes getting a CT scan with PO contrast is an easier modality to obtain. In addition to the CT, you can also identify any other intra-abdominal abscesses, not just in the upper GI tract, but sometimes other abscesses in the abdomen or in the chest, and other sources of sepsis as well. In terms of endoscopy, it has the benefit in terms of the upper GI tract, it's easily accessible to us. It allows for direct visualization, and you can assess the tissue viability. But the one thing to consider is that it does require sedation, and sometimes you do need to consider, especially in the upper GI tract, that you do need to protect the airway as well. These are just examples of different leaks that can occur. On the upper GI, the first image is a leak of following a gastric bypass. And these are two CT scans showing different ways that it shows leakage in terms of contrast extravasation, as well as a big air fluid level in the chest after an esophagectomy. In terms of endoscopic pictures, the benefit of this is you actually get to assess your staple line or anastomosis and the tissue viability. As you can see, that that tissue is not particularly viable. And these are just additional examples, and these are things that you hope not to see, but different types of perforations in terms of the chronicity. Some pictures show that one of them is a little bit more well-formed versus other ones that are smaller and more acute in nature. So in terms of how we control sepsis, I think these are all things that we all know, but just things that in the upper GI tract is a little bit more, we have to be a little bit more cognizant of is having ventilatory support and making sure you maintain their airway, making sure you start them antibiotics. But in the upper GI tract, I think a lot of us tend to always sometimes forget about nutritional support. We keep them NPO and can sometimes keep them NPO for quite some time. So having, making sure that you always, whatever approach you choose, making sure that you think about either a nasojejunal tube or placing a J tube if you decide to go in surgically is always good to have some kind of antral access to help with healing. So in terms of the controlling the leak, every leak presents differently, so it's hard to sort of standardize that approach. But in terms of the management, there are some certain factors that can sort of help us determine which modality to use. So it also ultimately depends on the extent of the leak, the size of it, where it's located, and what it looks like, and what the surrounding tissue looks like as well, just because if there's a severe inflammatory response in the surrounding operative field, it's going to make it more difficult to primarily repair it. And then also, I think the biggest thing is really what is the patient looking like? So if they're if they're in septic shock, obviously that's something that you have to consider where you need to consider an operation. So in terms of early versus late, I think the earlier the way we detect it, the way we can actually repair it sooner and it has lesser consequence to the patient. But if they are in septic shock, it's hard to not go to the operating room. Surgery's always been considered the mainstay, but I'm going to sort of challenge that prospect and go through some cases where endoscopy can be a way that we can manage that. But in terms of how we decide that approach, it ultimately depends on how stable your patient is, whether they can tolerate laparoscopy or a VATS if it's in the chest. But if they are stable, you can always consider doing using your interventional radiology colleagues to obtain external drainage or consider an endoscopic internal drainage, which is also probably going to be discussed in another talk. So again, in terms of what we do, in terms of the extent of contamination, obviously if there's free peritonitis and there's enteral contents everywhere, you have to obtain some kind of sepsis control. So in terms of an operation, that's probably where it's indicated. And you want to try to control that leak and turn it from a free perforation into a more controlled one. In terms of the in-tissue viability, this is where endoscopy does have a benefit, and I'm going to show some pictures of cases that I've had. In terms of repairing it, it ultimately depends on how early you detected the leak, as well as the tissue viability. So whether you're able to primarily reclose it is a possibility, but you also have to consider that it has failed for some reason, and you do need to sort of add something to it, whether that's an omental patch, similar to what we do for duodenal ulcer repairs, an intercostal muscle flap if you're in the chest. We can use fibrin glue and sealants, but it is most of the evidence supports that it's mostly for smaller perforations as opposed to large ones. So I wouldn't rely just on fibrin glue to seal your perforation. But essentially, if your tissue is necrotic at all, it may require some debridement, which I'm going to show you some pictures of what that means. It doesn't necessarily mean surgery, but sometimes it can mean how you can do that endoscopically. So in terms of the overall goals of management is really making sure you make that diagnosis early, and then once you obtain that diagnosis, making sure that you are able to wash that area out, clear the infection, place some drains, whether that's internally endoscopically or externally through a surgically placed drain or an interventional radiology placed drain, trying to repair the leak if possible, and then obtaining distal enteral access and trying to use a combination of these modalities is going to improve your success of controlling the sepsis and of repairing the leak, either by primary intention or secondary intention. So in terms of endoscopy, I think it's important to think about the different modalities you have available. I'm not going to dive too much into this, but it's important to use carbon dioxide when you do this, just because you don't want to cause tension pneumothorax or free air that can cause a lot of irritation. It's harder to clear. So it's important to not just use endoscopy as a diagnostic tool, it's also a therapeutic tool. I'll just go to the next. So this is just an example of one case, a couple of cases that I did. This is a patient that had a omental patch after a duodenal ulcer repair. As you can see, my my repair has failed. The omental patch has completely become necrotic. The patient was stable. I had the benefit of that and was able to debride my omental patch endoscopically through using a forceps and serially do this so you can see the differences in how the patch was essentially debrided completely off. But you have to combine that with also drainage. So I was able to obtain internal drainage with an internal pigtail stent, and you can see that the granulation response is quite good, and then it closed by secondary intention. So you can see that it is able to clear, and you're able to wash out the full cavity through the endoscope. So I just wanted to show that it is possible through endoscopy. I'll just go really quickly. Very similar example in terms of getting rid of the sutures and then as well as the necrotic tissue. And I also wanted to point out that there's a nasojejunal tube that was also placed endoscopically to maintain enteral access. And sometimes your debriding tissue is not necessarily necrotic tissue. It can also be endoscopic clips. So just keep that in mind. But this is just an example of a patient that I had that we did approach that both surgically as well as through endoscopy. But I think I just wanted to sort of show that you can do this in minimally invasive manner and turning that uncontrolled leak into a controlled leak.